Can you tell us a little bit about, we got to hear a little bit about your work. Can you tell us what is AT Still? It's this wonderful resource we have in Arizona, but what is it?
AT Still University, we have what I call the mothership or the main campus in Kirksville, where it all started. But Arizona School of Health Sciences is actually larger than the Kirksville campus. We have osteopathic medicine, we have the dental school, and occupational therapy belongs to the Arizona School of Health Sciences, where we also have physical therapy, athletic training, audiology, physician's assistant, and soon to come, speech language pathology. So we'll have all the therapies over there. And it's a great place to work because, we believe in the mind, body, spirit, and the university is very committed to serving the underserved population, which is actually philosophically very well aligned with what OT is all about. And that was what drew me here because of my commitment to social justice and those issues. So here it is embedded in the mission of our university, commitment to serving the underserved population.
Now, when you say serving the underserved population, is that just in training future service providers, or is the community actually interacting and getting services sometimes with AT Still?
So, the AT Still has many community partnerships, and it takes shape in very different forms for different disciplines and departments. So I can speak confidently about what happens in my department. We have throughout our curriculum, we have embedded what we call curricular threads, which deal with community health, and we also have an embedded public health certificate in our degree program, and lots of assignments and rotations where we place students in the non-traditional community settings, particularly for doctoral capstones. We are limited for community setting for other than healthcare and education for clinical rotations because we have mandated the students be supervised by an OT. But wherever we can have non-OT supervising our students, we have built in a lot of interaction with our communities.
Fantastic. And I know that we've been invited to speak and interact in various ways with AT Still. We always appreciate everything you do to help people have real world experiences before they graduate. Can you tell us a little bit about what occupational therapy is? At Brain Injury Alliance, we work with survivors at all points of injury, and some have gone years after injury without a formal diagnosis or any sort of treatment. So can you tell us a little bit about what is occupational therapy?
Occupational therapy celebrated its 100 years in the United States in 2017, but it is still a very not very well understood profession, I should say. People always confuse us with PT, or they define OT as what PTs cannot do. But in one sentence, I would say occupational therapy teaches people skills for the job of living. So we look at everyday activities and what has been disrupted due to a pathology or an injury, and we help people function in their everyday life in the arena of them being able to take care of themselves, to continue with what we call productive occupations, that is going back to work, going back to school. We work across the lifespan. And I can tell you one thing that is different, definitely different from PT to OT since I taught PTs, is occupational therapy looks at the whole person in terms of physical issues, cognitive issues, emotional issues, behavioral issues. So we can do mental health, physical health, and cognitive rehab and things like that. So it's much more broad scope of practice, and it looks different in different context settings. So with related to concussion, I got interested in this because in my course, of course, I was influenced with Tamara McLeod, who's the next speaker, but I thought here's a great connection. Let me look into concussion in the area. And also the challenges to practice, which is so constrained by reimbursement in terms of particularly my interest being in cognitive rehab, because I feel that people get services for concussion. We have very good clinics, and I've collaborated with Barrows and with Banner. But because of the scope of practice being so broad, different aspects of practice are utilized in different clinics. I feel that there is a there is a challenge to doing cognitive rehab. I understand that, but there is a gap in service as far as cognitive rehab is concerned. And I think with concussion, it's a brain injury after all, right? And it's very mild kind of deficits, which I think can be remediated, but there are no services. And that's why one of the projects that we are working on right now, and I hope to collaborate with your organization, is to develop a return to work program, which actually includes cognitive rehab in it. And in some ways we can offer it to grant funded or at least advocate for reimbursement in something like that, because I feel it's a much needed service.
That is absolutely much needed. Sometimes when you're injured and you're not back to performing certain duties, whether it's pertaining to childcare or work, sometimes you don't know what the deficits are. It can be very, very hard to find that out into the recovery.
Right. And the deficits, as the speaker spoke in the first video, the post-concussion syndrome, they live with some of these. They know that things are not back to what it was before, and there are fatigue issues and mild kind of cognitive issues, and so I think these can be remediated or at least compensated for, so that people can have a full life and the quality of life and well-being can be enhanced. And that's where occupational therapy comes in.
How do you, for the students you work with, how do they usually arrive at being an OT? How do they know that that's their career path?
Occupational therapy is the third highest ranked healthcare profession and seventh in all professions in the US. So we are up there in the Bureau of Labor Statistics if you look at the data. But people come in to OT when they decide to choose a baccalaureate health profession track, if you will, which some universities offer. And truth be told, they're shooting their arrows at multiple health professions. And many of them apply to both PT and OT and hope they can get into one of them. Although there is overlap in the profession, but there is a significant difference. That's why we are two independent professions. So if they have a lot of the basic sciences, and we also have, by the way, we also have athletic trainers who have become OTs. In fact, that was one of my students with a very strong athletic training background, came to OT school for a doctoral program, focused her studies specifically on concussion, and that's how I got introduced into the concussion field. So these are students who want to be in health profession. And with regard to OT, at this point in time, we offer entry at 2 levels, and the board exam is the same. Students can take a 27-month master's program, or they can take a full 3-year doctoral program. So some students select, and we have a larger master cohort, and we have a smaller doctoral cohort because, it's extra 1 year's worth of studies. So it has to, the students who come into OT, they always say that they come in because we are whole person healthcare, holistic. A lot of professions are holistic too, but they come in with very strong interest in pediatrics, for example. Nearly 30% of occupational therapists are pediatric therapists, the remaining being in adults. So a lot of them come and they get into the school system and other settings for pediatric therapy. And these are people who have encountered OT either through some family members, because nobody is, in childhood or when they're looking for a career, they say, I'm going to be an OT. It's not like I'm going to be a doctor. It's not like that, because people don't know us very well. So they have encountered OT, or they have encountered in their work setting. The other group of people who come and get a second degree and come to OT are the behavior therapists. The people who have done the ABA training. They find that they say, tell me, the students who come from that area, I worked with a behavioral therapist, and I saw that when the OT was working, I was so impressed by how they use everyday function and activities and make a difference to people. So different career paths, lead people to occupational therapy.
I love that. The work that they do before they go out, before they graduate and become practitioners, you do, it seems like, such a great job exposing them to so many different things, including brain injury and how brain injury actually presents and how brain injury can disrupt quality of life. How did, since the work you do is so important, let's talk about the COVID elephant in the room. How did COVID disrupt life at AT Still and how you teach?
Yeah, I was very fortunate to be working at a university like AT Still University because our president is extremely committed to following the CDC guidelines, and he created a group of upper level administrative people who were routinely monitoring changes. It was like a moving target for us. I remember still March of 2020, I was on campus one day and then I was off. And I never went back to my office for more than a year. It was like we had to pivot extremely fast. And so they took a phased approach to handling COVID. So in the first 3 to 4 months, none of us were allowed back on campus. So within 24 hours, we were remote learning. Everything was online. But one thing I did to keep consistency for the students, and many programs took this approach, it was the same schedule we maintained. And instead of meeting in the classroom, we met over Zoom. Of course, at the end of it, we're all totally zoomed out. But at least they had the structure and a live faculty teaching them versus passively observing a PowerPoint, asynchronous kind of learning. We didn't do that because our students come for the face-to-face. And I think that helped them maintain the routine. When routines are disrupted, it's really hard. First of all, the major adjustments students had to make, and not everybody likes distance learning and remote learning. And that was a huge shock for our students. But they were troopers and they went with the flow of things. Faculty were able to pivot and adjust. We had to make some curricular changes because, as you said, hands-on skills is very important for occupational therapy. So I had to rearrange courses. And later in the phase where we were allowed to come back to campus, we were allowed to come back only for what we deemed as essential labs. That means those skills could not be taught remotely. Whatever we could teach through Zoom, we did it. Otherwise, we brought them in very small groups. And usually we have 3 lab sections in OT. We had 6 to 10 lab sections so that we could keep it in that very small group. So for faculty, it was teaching multiple groups of students over and over again. But that's how we try to make sure that the students' graduation time was not disrupted because of COVID. It impacted our teaching because many clinics could not take students for clinic rotations. And that was the major impact, how students were, because they come and they value so much the 24 weeks they get of clinical rotation. And when that got disrupted, and for the doctoral students, the sites that we're going to take, like I was going to send 2 students to Banner Concussion Clinic, they were not taking students. So I had to come up with an alternate place for them. So projects had to be changed. And I think the students really missed the hands-on learning, and we did the best we could. We did give them the choice. If you're okay about delaying your graduation, we will let you do the clinic after this pandemic settles, But now it's like, who knows when it's going to be settling, right? Nobody could predict what was going to happen. But I'm happy to say that students graduated on time. We were lucky that we were able to place all our students. But truth be told, we were restricted in the settings where we could place our students. Inpatient rehab, it was next to impossible. We couldn't place people. Acute care, we couldn't place people. So many of it was outpatient and in the school setting that we were able to place.
So when you talk about that piece where they go out into the community and start to, can you say a little bit more about that? So they would, for lack of a better word, the job shadow. So they're learning in the field with different professions. That was really hard to access then during the pandemic. People were barely operational, keeping things going. They weren't letting anything additional happen.
Right. The change, first of all, it is not just passively job shadowing. This 24 weeks that we are mandated to do is by the end of it is 12 weeks. We have 2 level 2 field works, what we call level 2 rotations. So in those rotations, at the end of each of those rotations, they should be able to practice as entry-level therapists. So it is not passively job shadowing, because towards the end of the 12 week, they should carry a full caseload as a full-time therapist in that particular setting. So for the students, the learning was really impacted. And, we can say that, oh my God, we were able to still do it. But let's be honest about it. There is a huge difference when you can touch a patient and you can feel spasticity or muscle tone differences. And telerehab was being used in many of these places. And but it's not the same. And one of my students told me that in a pediatric outpatient setting, the parents, they were working from home. They couldn't devote the computer to 1 hour of rehab with the other kids in the house whom they were trying to school. There were lots of challenges to the families, especially with children. It's a little bit easier with adults, but especially with regard to concussion, we are adding extra screen time to our patients to give the rehab. That was, it was really challenging, I'm sure, for the practitioners. But, some therapy is better than no therapy, I guess. So.
That's fascinating. So that whole process bridges your book learning into really going into a fully operational clinician. And that's fascinating that they were kind of having the experience too. They must have had anxiety around learning online and their own challenges at home. And then they're seeing that in their patients as well.
I know. And for the students, they did not come anticipating remote learning, because they come to a program because we give access to faculty and things like that. So the telelearning itself doesn't work for everybody. It works for some people, it doesn't work. I think for the students, what we noticed was the mental health issues was on the rise, because we get students from across the country. And especially the new cohort that started in 2020 July, they met each other on Zoom, where starting from orientation to graduation in the academic cycle, everything was happening virtual. So these people did not even know their classmates. I saw my students in that cohort 1 year after that, because I had not seen them on face-to-face at all. That was very challenging for these students. And they missed that being on campus, accessing library, just hanging out with friends and doing group work and studying. None of that was possible because we did not allow it on our campus. What they did for socializing, it's very different. But I think they had extreme socialization, especially those who left their family and came over here. They did not have a social support network in Arizona. It was really hard for them. No doubt about that.
So they missed out on those shared experiences, that in-person learning and feedback, and just being able to socialize with someone going through the exact same thing that you were going through, that learning.
And then what surprised me is that I was thinking, hopefully this younger generation that live on social media and the virtual reality, maybe now they realize that human contact is important. Because they could not handle it. They're not having the socializing that's going on. We had many virtual socializing events, come and get to know your faculty. But after sitting almost the whole day on Zoom attending classes, they're not motivated to add an extra 1 hour to come and hang out with faculty. And I don't blame that. The other impact that it had on students is that the settings where occupational therapists work, unless you're working in the older adult kind of setting, or maybe in acute, in occupational therapy, we don't deal with death and dying as often as some professions do. I remember getting calls from students who had graduated just that previous year, crying on the Zoom meeting with me, saying that, Dr. Gupta, when I became an OT, I did not think that I was going to see people dying around me. And they were, and I don't know, different facilities, what they had set up for the professions, young professions, novice therapists to deal with it. But that was very hard to come to terms with that, and the impact it had on their own mental and emotional health. These are some, we teach them about death and dying and grief. Learning something theoretically is very different from being affiliated with an acute care unit where every day X number of people are dying. And that's very different for these students. I did not think about it. And when the student reached out, and I'm glad that they reached out to me, that I was able to meet and talk. I'm a mental health professional. So I was able to put on that hat and just listen to them, that it happens, but look at the learning that you have. It's easy for me to say. It's a learning. Everything is a learning, right? But to be privileged to be there to support the families during this difficult time and things like that.
That's it. Yeah, our healthcare workers are human beings. That's so important to remember. This last year, as we've learned about the neurological challenges that can emerge post-COVID, for those who are still going to be symptomatic after recovery, has your institution or your program been asked to do any different specialized training or to prepare people in a different way to help those after the pathology of the virus?
The thing is, the wheels of accreditation, they rotate very slowly, so they cannot suddenly throw in a new standard, right? But what they did was they allowed unilaterally, because of Department of Ed, we are accredited to be a residential program. But they say until and unless your campus opens up, every program across the country was allowed to do remote teaching and learning and things like that. But we already had within our 2018 standards in occupational therapy, telerehab. Telehealth has been included as part of one of the standards. But we have like 100, I don't know, the last time I counted 150 standards. So we have to cram all this in. So we kind of touch all these, but not in depth about telerehab and how it's done. So in some sense, it was good to come for the students who went and experienced this in the clinic to come back and tell us. I would ask them, so how did it impact your learning? And how did you think giving occupational therapy treatment virtually, how were you able to do? And the greatest challenge was for those with pediatrics. So of course, we are now embedding in our curriculum, discussing telehealth in the context of mental health practice, context of pediatric practice, because I think telehealth is not going away. It's going to be here. And there are pros and cons like everything else, right? You can reach people in remote areas, but I think the challenge is doing telehealth for pediatric population. Children, you can't do talk therapy with children. And PTs who work with pediatrics, we use play as an occupation to keep them engaged, to modify their behaviors. It's a very different experience when you're not there with the child and building a rapport with the child virtually, right? So you're depending a lot more on patients. So we are discussing learning from our students' experiences, learning from practitioners' experiences, and teaching that to our current students so that they know that telehealth is going to be part of their future practice in which are beyond the pandemic, So that part of it we have embedded in the curriculum. The other thing that we have done in our curriculum is that, one of the things the pandemic showed was, it was surprising to all of us that at the systems level, we were not prepared for this. Like we scrambled around and we dealt with it, but we were not really prepared. And one area of practice that OT is a specialized area for OT, but we have started addressing this in our curriculum is disaster preparedness. How can occupational therapy assist with people who are experiencing trauma and with disasters, natural disasters, whatever have you, fire, you have lost your home, or Katrina that happened during the hurricane. In the context of disaster and people dealing with trauma, the role for occupational therapy, that we are going into that in a little bit more detail in our curriculum. Because working with people who come with this current trauma is different from your everyday practitioner. It's a little bit nuanced kind of practice, and we're trying to embed that trauma-informed care into the occupational therapy curriculum.
That must be really interesting for you because you have that refugee, really you've done the research and kind of looking at trauma from that point. So are you almost kind of pulling some of that into looking at helping people through COVID, helping people through natural disasters?
Yeah, I hope I can do that through my faculty because I don't teach very much, but definitely I have town halls with students. Trauma is trauma, right? And it takes different forms. And human displacement, imagine that you have no country you belong to. I mean, how much more traumatic can that be? That's how I focused on working with human displacement, people who came into country, who were forced to they have lost everything in their life, everything, home, family, relations, and everything, right? So of course, there are common threads that one can draw across that we can communicate to our students about the trauma-informed.
And this isn't an abstract, kind of context at all. We have people arriving right now who were able to flee Afghanistan. So we have people, real world things definitely going on where that can be applied. And your comments on telehealth were so interesting because I think this has gotten forgotten over the last year and a half, but telehealth was kind of, I don't know if it was, you would say controversial, but like you couldn't always get reimbursement for it. It was kind of really scatterplot where you could use it or not. A lot of therapists didn't use it. And then all of a sudden the pandemic happened and it fast forwarded about 10 years. It just like shot through all this bureaucratic red tape. And here's something that I keep remembering and finding funny. We had worked with, Brain Injury Alliance had worked with AT Still on a joint grant where we would go in together for some monies that would allow Brain Injury Alliance to do resource facilitation off hours. So evenings and weekends when parents could be done with work and be able to focus on meeting the needs of helping their child live well after brain injury, but we'd be partnering with the infrastructure of AT Still. And this was about a year before the pandemic, and it was controversial. People didn't know if it would be embraced, if we should even do it, and we didn't get funding. So I think that's kind of funny. We've really forgotten about that and just fast forwarded through about a decade into acceptance of telehealth.
Yeah, and I think in this is the right segue for me to mention that we have started a pro bono OTPT student-led clinic, but of course faculty supervised, right? And it runs in the evening when there are no classes on campus. We use labs to do rehab for people who either have no insurance. We don't even ask them about insurance. Anybody can walk in. If they have overutilized their insurance or underinsured, no insurance, we don't care. They just come and they sign up and we give them free rehab in the OTPT clinic. And we can talk about this, Carrie, later, but one of the things is working parents being able to who live remotely, who cannot drive into therapy, and being able to focus in the evening when, day life has come to an end, because our clinic is in the evening, 5 to 7. So to have like a group session, like a support group even for parents of children who have concussion, strategies that we can give them in managing behaviors. There's lots that we can be done in educating the caregivers, if not giving active therapy to the children, but helping the parents manage children who are dealing with concussion and brain injury. Definitely a lot can be done. And the fact that Arizona was leading. It was one of the states that were ahead of the curve when Governor Doug Ducey had the executive order and opened up telemedicine, that everybody should be allowed across the different settings. Now I think he has got a new one where it's audio also if people don't have video. That was having legislation behind telemedicine is very important. It's like being officially sanctioned. Yes, go ahead and do it. And moreover, by the way, you cannot cut them for the reimbursement because of doing telemedicine. That was a very powerful message to come from people who have the power to bring about change at the systems level. And people realize, I think what it has taught, at least I'm not one for distance education. I don't like it because I like the dealing with people face to face. But, the pandemic has taught us that having an open mind is good because a lot of things can be done. Like everything else, there are advantages and disadvantages. So we can make trade-offs. So imagine if a working mother who's very difficult cannot come to the clinic in the daytime, things like that. Can we give hybrid rehab? Come for X number of sessions, the rest we can do virtually. I think it's time for innovation. How can we leverage technology in reaching people, who have insurance, who don't have insurance, and supporting them through dealing with things like concussion, including caregiving. Yeah.
So that we're really meeting people where they're at for that service delivery. Well, this is fantastic. We could talk all day. But we're not going far from the campus. We're still going to be on campus at AT Still. We're just going to have Dr. McLeod join us.